Hi, this is Sydney, and I am filming my head-to-toe assessment. I'm just going to pan the room to make sure there is no cheating. And there's Brendan. Alright, so when I first walk into the room, I am going to check the patient's chart, see why they are visiting, and see if they have any current problems or past problems that we need to be aware of. I am then going to wash my hands and then provide for privacy for the patient. I'm going to walk in and introduce myself to the patient. Hi, my name's Sydney. I'm going to be your nurse today. How are you doing?
I'm good. How are you?
All right. Can you tell me your name and your date of birth?
Brennan Wiederman, September 15, 2001.
All right. And do you know why you're here today?
Just a checkup.
And do you know where you're at?
The doctor's office.
All right. Just from this that we can see that the patient is alert and oriented types 3. First of the head-to-toe assessment, we're actually going to start by looking at all of the cranial nerves just to make sure those are all intact before we continue on the rest of the examination. So my first question is, do you have any problems smelling? Have you noticed a change in smell? Can you not smell anymore?
No.
Okay. This shows us that cranial nerve number 1 is intact. And I see you wear glasses. Do you also wear contacts?
No, just glasses.
Okay. And this shows us, we would further follow this up with the Snellen chart, and this is where we learn the 20/20, we learn 20/40, 20/60. We would be able to see from the patient of what they can read from where a person with normal vision can read the same chart from. So this shows us that cranial nerve number 2 is intact. Next we're going to do the cardinal gazes, and we're actually going to move the pen in 6 distinct places, so the eyes have to follow without motion of the head. Alright, so I'm just going to need you to move your eyes for me. Alright, and those were normal findings. His eyes were able to follow as I move the pen around. So this shows us that cranial nerves 3, 4, and 6 are intact. So next I'm going to move on to the TMJ. So I'm actually going to put my hands on your jaw, and I'm going to have you open those up. Right, and close. And this shows me that cranial nerve number 5 is intact. Now I'm going to have you smile, frown, and this shows me that cranial nerve number 7 is intact. Alright, and I'm actually going to have you sit up on the bed a little bit, and I'm going to come behind you and I'm going to whisper 3 words, and I'm going to need you to repeat them.
Alright. Orange. Electric. Christmas.
Alright, this shows that cranial nerve number 8 is intact. Alright, I'm going to have you move back.
Okay.
I'm now going to have you say ah.
Ah.
Alright, and you can move your tongue back in and just have your mouth open. Alright, now this shows that the gag reflex is there, and it shows that cranial nerve number 9 and 10 are present and intact. And can you shrug your shoulders for me? Alright, you can unshrug. This shows that cranial nerve number 11 is intact. And then can you say light, tight, dynamite?
Light, tight, dynamite.
Alright, this shows me that cranial nerve number 12 is also intact. So going through all the cranial nerves, they are all intact, so we can continue on with the normal head-to-toe assessment. So looking at him, he is appropriate color for his actinic normal. As I'm feeling his skin, he is warm, and he is dry. There are no lesions. There's no bruising. And as I'm actually going to go check up here for tenting, there's no tenting apparent. So he is hydrated. As I'm looking at his skin, there's no edema. And as I'm looking at him, he's very comfortable, relaxed, and doesn't appear to be in any kind of distress or pain. So, are you allergic to anything?
Mainly like grass.
Grass, what happens?
I get red and splotchy.
Red and splashy. Does your throat close up?
Yes.
Yes. Have you ever had to go to the hospital for it?
No.
Do you take anything for it?
Sometimes I'll take Benadryl.
Okay. And does it normally dissipate after a few hours, or is it a last kind of all day kind of thing?
After all day, if I'd wake up the next morning, it'd usually be gone.
Okay. Are you allergic to any medications?
No.
Any food?
No.
Okay. Have you had any surgeries in the past?
I had tubes put in my ears.
Do you know how old you were?
2.
2? And have you had any complications from that procedure?
Not really.
No? Alright. Do you have any scars, lesions, bumps on your body?
A scar one above my eye.
How did that happen?
I got hit with a baseball bat.
And did that heal pretty normal? Did that heal in a good amount of time?
Yeah.
Yeah?
Got stitches.
Okay. Alright. Do you have any family history of any heart disease, lung disease, any stomach problems, any cancers?
Cancer.
Cancer? Do you know what kind?
Lung cancer.
Lung cancer? Okay. So that's more to be advised of. Did he have lung cancer from smoking or?
Smoking and asbestos in factories.
Yeah, so it's best advised to stay away from smoking because it can lead to lung cancer and it can lead to other problems in your body. So after that brief little health history we had, do you want to stand up for me so I can look at your spine? Alright, as I'm looking at the spine, it is symmetrical, it is straight, there is no deviations in the straight line, there is no curving. I'm actually going to have you walk forward so I can watch your gait. And the gait is steady and it is even, and he's able to do it with ease. Alright, so I'm going to actually have you sit down on the bed. Alright, so I'm going to have you do some range of motion stuff for me. So I'm going to have you lift your arms over your head. I'll have you lift them behind your back. Lift them in front of you. Alright, you put your hands down. And then with your hands themselves, I'm going to have you do pronation, which is just having your hands up. And then supination. Alright. And next for the range of motion, I'm going to have you move your neck to this side. I'm going to have you move your neck to this side. And back. And then front. And then I'm going to have you lift your legs up. And I'm going to have you lift them down. And I'm going to have you just move your foot at the ankle. Okay? Now, through this full assessment of the range of motion, the patient has full range of motion in the arms, legs, neck. There is no strain, there's no pain, and there is no struggle to do an easy movement of the body part. All right, so I'm going to have you lay back down on the bed. All right, so now as we move on to the head part of our assessment, we're first just going to look at the skull and the head itself. As I'm looking at it, it is normal cephalic and atraumatic. It is symmetrical. It's got 2 eyes on both sides. Pretty even. 2 ears. The hair is evenly distributed. Now as I go into the hair, we're looking for any lice. We're looking for lesions, masses, bruises. And there isn't any. And the hair is well groomed. And you can tell that there is hygiene involved in there and that the hair is well washed. Remove this for a second. And so, by seeing that, we can see that the patient also, from just the face, and we can see that they do have good hygiene, that they are washing behind the ears, they are washing the hair, there's no dirt, everything is clean. And now as we're looking at the face itself, the eyes are symmetric, the nose is symmetric, and the lips are symmetric as well as the ears. I actually have you take these off for me real quick. So first we're going to start with his ears. And as I'm looking at his ear, I'm actually going to pull his pinna, pull the tragus back. Alright, and on both sides of the ear there is no redness, there's no swelling, there's no drainage, and there's no edema. And earlier in our cranial nerve test, we were able to see that he doesn't have trouble hearing and he's able to hear us, showing that cranial nerve number 8 is intact, and he's able to answer our questions. And now as we move on to the eyes, I'm just going to have you look at me. We can see that the eyebrows and the eyelashes are also evenly distributed on both sides. Now I'm going to have you just look straight at me. And I'm going to pull these down real quick. We can see that the conjunctiva is a light pink and that the sclera is a white. That we can see that the pupil is even on both sides. And the iris is the same color on both sides. So now what I'm going to test is for accommodation with his eyes. So I'm going to have you look up into that corner of the room. And then when I tell you, I'm going to have you look back at this pen in front of your face. And we're going to see if the eyes can accommodate to that. And you can look now. Alright, so the eyes are able to accommodate to the far away object, to the near object. Now before I actually started this video, my pen light actually died on me. So we're actually going to test indirect and direct light, but in that doing, we're going to actually explain more or less what it is, since I don't have a light to actually show you. So when we're testing for indirect and direct light with the eye, we would bring the light directly in front of the one eye, and then we'd bring it back. Don't follow me. Just watch. Just look forward. Alright, so we'd bring it in front of the one eye, and now this eye right here would accommodate and dilate, and then as I brought it back, and then as I brought the light back, this eye would also accommodate and dilate as well. So that is the indirect and then the indirect. So in the second time through with the light, the second eye would then, in action to the light, hitting the first eye, would then dilate with the light as well. So as we're looking at the perla of the eye, the pupils are round, they are equal, and along with the perla is also the accommodation and the indirect and the direct light, making sure that the eye is able to dilate. So next part of our exam, we're actually going to move to the nose. So I'm looking at the nose, if there's a deviated septum, and there isn't. And inside the nose is a nice pink, moist color. Mucosa is a little moist. There's some little blonde hairs in there. But overall, the nose is symmetric, and there's no presence of that there had been ever a broken nose, and that there is no deviated septum. Do you ever have trouble breathing through your nose?
No.
Do you ever start when, like, if you're running or if you're sleeping, are you a mouth breather or are you a nose breather?
Running, I'm usually a mouth breather. Sleeping, probably nose.
Okay. All right. And next we're going to move on to the mouth. So actually I'm going to have you just smile for me. So we can see that he has braces. And as I'm looking at the gums, they are intact and they are clean. We can see that the teeth are clean. And they are well taken care of. And I'm actually going to now have you open your mouth for me. Alright, the tongue is a pink moist color. So is alright, and the uvula is at a +2 or a +1, as well as the tonsils. And there is no redness or swelling in the mouth. The lips aren't chapped. They're a nice rosy pink color. There is no sign of dehydration when looking at the lips. And just overall looking at his face, it's very symmetrical, very healthy, and other than the glasses, very normal. So next I'm going to actually move on to the neck part of the assessment. So I'm actually going to look at your lymph nodes of the neck. So I'm actually just going to come around and sit right here. I'm going to actually have you scoot back this way a little so the camera can see us. Alright, so first we're going to deal with the occipital, so we're going to palpate these. And these should be non-tender, non-palpatable. So this is the occipital, the preauricular, the postauricular, the submental, the submandibular, and just let me know if you're in any pain or tenderness when I'm doing this, alright? Alright, and then the superficial cervical, the posterior cervical, and I'm actually going to have you tilt your head to one side, and this is where we're going to feel the deep tendon of the the deep cervical chain. So when we have him bend his neck one way, we can feel it relax, right? Do it the other way. And it's easier for us to feel it because when it's all scrunched up, when our neck is stiff, we're not going to be able to feel those. And as I move down to the clavicle, I'm going to feel for the supraclavicular. Alright, none of these lymph nodes were palpable. And were you in any pain? Was it tender?
No.
And the patient reports there was no tenderness. So I'm actually going to come behind you. And I am going to feel your thyroid. Now I'm going to come at you from behind.
Okay.
I'm actually going to put my hands around your neck. And when I do this, I need you to swallow for me. Alright, so he swallowed and I was able to feel where the thyroid is. There's no deviation. And as now I'm feeling for the trachea, there also is no deviation again. Could you swallow for me again? Also, when feeling the thyroid, I don't feel any masses, nodules. I'm going to stop choking out. I don't feel any masses, nodules, and again, there's no deviation there or with the trachea. Alright, so I'm going to have you sit back down. Sit back against the bed. Alright. So, as we're moving forward, we are now going to assess your lungs and your heart. So first, we're going to just ask some heart questions. Have you ever had an abnormal heart reading? Have you ever gotten an EKG and they said that you've had a murmur, or have you ever been to a doctor and they've listened to you and you've had a murmur?
No.
No? Do heart problems run in your family?
No.
Do you ever get dizzy when you stand up too fast?
No.
And do you ever get out of breath for no reason?
No.
Okay. Are you a smoker?
No.
Okay. And do you drink?
No.
Okay. So, just looking at his appearance, he is not in respiratory distress. There are no accessory muscles being used to be able to breathe right now. And just looking at him, he looks like he's breathing at a normal volume intake. And he looks very comfortable. Alright, so I'm actually going to have you sit up again. I'm just going to have you sit up for this next part of the portion of the assessment just so I can assess your lungs and your heart without you laying down. So first we're going to measure the AP diameter. So this should be a 1-to-2 ratio. So I'm going to take my hands, and take the side of his chest, and then I'm going to bring it to the back, and it should equal to both sides of his chest, to both sides of the back wall of his chest. And this is where the AP diameter should be a 1-to-2 ratio, which in this case it is. So I'm actually going to test for tactile fermentus next. So I'm going to put my hands on your back, and every time I lift up, I want you to say 99.
Okay. 99.
My hands are on your back.
Oh, 99. 99. 99. 99.
Okay. So, the closer I was up to the top of the lungs, where I was at the base of the lungs, I was able to feel the vibrations of the 99s, and the lower I went down, the sound actually deceased, and I wasn't able to feel the vibrations as strongly when I started. So next, I'm going to listen to the lung sounds on the posterior side of the body, and then when I go to the anterior side of the body, I will also do that and listen to heart sounds as well. And every time I lift up my stethoscope, I'm just going to have you breathe for me. Alright, for the posterior lung field, there was no wheezing, there was no rales, there was no gurgling sounds, there were no adventitious sounds heard. They were very clear, they were at a normal rhythm and rate, they were not forced, and he was not out of breath doing that for me. So now I'm going to move to the anterior side of the body. I'm going to have you scooch towards me a little bit. And the same thing. And just let me know if you're in any pain at all during when I'm doing this, alright? Alright, and doing the anterior side of the lung field, there was again no wheezing, no rales, there was no gurgling, there were no adventitious sounds to be heard, and again, the rate was normal and the rhythm was also normal. He was able to do so without becoming out of breath, and he did it with ease. So next we're going to move on to the heart. It's important to be able to assess where the heart sounds can be heard. This is when we use ape to man, and it's important to know where they can be found, and the landmarks actually help us find them easier. And so this again, I'm just going to listen to your heart. There's nothing I need you to do. Just going to listen to your heart. So first we're going to start at the aortic, which is in the second intercostal on the right side. The pulmonic, which is on the second intercostal on the left side. We're now going to move down to the third intercostal on the left side, listening to Erb's point. Now we're moving down to the fourth intercostal, listening to the tricuspid. And we're moving down to the fifth intercostal on the left side to listen to the mitral. Alright, now in all five of these heart sounds, S1 and S2 were present. The apical heart sound was found at the apex. And I'm actually going to just listen to the mediastinum, which in itself is the heart, and just making sure that we hear the heart sound just in that overall point of the heart. Alright, and the heart sound S1 and S2 were also present there as well. Alright, now looking at his chest, I'm seeing no heaves, along with there's no pulsations, and you can't see the beating out of his chest, more or less. And that is all very, very bodily function that is in control, and we're not able to see above the skin. So the next part of our exam we're going to do is the JVD. So I'm actually going to have you, I'm going to bring back the blue pillow, and it's going to elevate your head. So in a hospital setting, we would elevate the bed to an angle where we had the patient sitting upright, such as this. and we would be able to see, I'm going to have you lay back a little bit, we would be able to see the fluid build up in the jugular vein. And when we move the pillow down, or if we move the bed down, we should be able to see the fluid run out. But if the fluid doesn't run out, this is when jugular vein distension becomes a problem, because obviously there's a backup somewhere in most likely the heart that is allowing the fluid to stay there and not be able to be released. So as I'm looking, the vein has filled up, and so in a very gentle way, I'm going to remove this pillow and I'm going to lay him back. And the fluid has emptied the JVD, so we can see that there isn't a blockage in the heart that isn't allowing the fluid to escape. So next I'm going to listen to his carotids. I'm actually going to palpate them first. And by doing this, we need to make sure that we do it in 3 spots. And we also need to make sure that we do it one side at a time so we're not knocking the patient unconscious. So I'm going to start with his left side. I'm going to have you turn your head. And if you could not breathe for me for a second.
Okay.
All right, you can breathe. All right, I'm going to have you turn your head the other way. Alright, you can breathe. Alright, so what we were looking for in there, we were looking for thrills with the palpating of the carotids. And on both sides, there were no thrills present. Both pulses on both sides were equal. They were at a +2 grading, and they were bounding as well. So next, I'm going to do the same thing, except I'm going to oscillate with the bell. So I can hear if we can find any bruits in the carotids. So same thing, just don't breathe from me. Right, you can breathe. Right, and again. Alright, you can breathe for me again. And after auscultating the carotid arteries, there were no bruits present. And again, the pulses were bounding and they were easily heard. Alright, so our next part of the assessment, I'm going to do the abdomen. So first we're going to actually auscultate with the diaphragm. And we're going to be listening to bowel sounds. Now it's important to auscultate before percussing or palpating, lightly palpating the stomach, because we want to leave the stomach and the bowel sounds alone before we actually put the diaphragm on it, because if we actually were to palpate, we would stir up the stomach and we would be hearing bowel sounds, or we would be hearing noises that we wouldn't normally hear, or we would hear almost kind of fake. They're kind of more man-made by us, instead of just letting the body give us the sounds that it wants to give us, instead of creating the body to give us the sounds because we have touched it. So I'm just going to lift up your shirt. Alright, so we're going to start in the lower right quadrant. And then we're going to move to the upper right quadrant. Upper left. Lower left. Okay, so all bowel sounds are present in all 4 of the quadrants. And as I'm looking at the stomach, there are no masses, there's no lesions, there's a few freckles, it is symmetric on both sides. There's no pulsations from any of the arteries. The chest on both sides are even. And this is also the time when we were doing the abdomen that we would talk with female patients as well as male patients about self-breast exams. We know that women do this a lot to check monthly for lumps and bumps on their breasts that aren't normally there, but it's also important for male patients to also be aware of that because breast cancer is something that does happen in males as well, and it does get passed a lot because men don't think that they need to also perform a self-breast exam. So that's important to just be able to take a shower and to be able to feel your chest and your nipples, making sure that they're both equal on both sides and that there are no new lumps or bumps there. Alright, so the next part of the exam, I'm going to palpate the abdomen, and I'm going to lightly do it, but if at any point in time it hurts or tender, just let me know. And it's important to do it at least in 3 spots in each quadrant to make sure that we're able to feel anything that we might have missed. This is the time that we would feel lesions or masses that were there because we can't pick it up like this. We just pick up the sounds with this, so this is the way that we're going to feel if there's anything there. Alright, was any of that tender?
No.
Alright, I'm going to move this down for us. Alright, so I was able to feel, palpate the liver in the upper right quadrant. I was also able to palpate the spleen and feel that as well. And in any case, you would be able to, in a light palpation, you can lightly feel the spleen, that it is there, but you can't fully feel it. It should be a concern when you are lightly palpating and the spleen is enlarged, because this is when we need to stop palpating because this can cause a rupture and we need to address that immediately. So the next part of my exam, I'm actually going to check your pulses since we are in the pelvic region, and we're actually going to skip the femoral and popliteal because in a hospital gown it's a lot easier to do when a patient is wearing pants, and it's less invasive when they're not wearing pants and you're able to provide for some privacy for them. So we're just going to do the brachial, the radial, and then we're going to do the tibial and the dorsal pedialis. Alright. Dorsalis pedis. Alright, so I'm going to actually have you give me, I'm going to actually take this one. And I'm going to take this one as well. Alright, and feeling the pulse. It is at a +2, and they're equal bilateral. And moving up. The pulse is also equal bilateral, +2, grading. And so now as I move down to the feet, it's just going to be easier if I do it like this. So I'm going to go almost to the bone on the side of the ankles. Alright, and these are also equal and bilateral on both sides. They are the same. And a +2 grading. Alright, and then the dorsalis pedis, the grading is also +2, and they're equal on both sides. So, next we're going to actually just ask some questions about the pelvic part of the examination due to the fact that we are not in a hospital setting, and this is just a YouTube intensive video. We're just going to ask some questions. For a male, we would look at the genitalia area. We would look for lesions, masses, making sure that hair growth was normal. We would ask the patient if they have any trouble urinating, if they have a burning sensation, if there's discharge. We want to make sure that everything is normal. In a female, we also would look for masses, bruising, lesions, also even hair distribution. We would ask her about her first menstrual cycle. We would ask her if she was experiencing painful periods, if there was excessive bleeding. And I'll give you back your glasses so you can see. If she was going through menopause, how many children that she's had, if she's had them vaginally or if they're C-section. We then would ask any miscarriages. We then would also assess if she was also having trouble urinating, if she was going the same as the male, if she was going up to the bathroom a lot at night, if there's painful urination, if there's any blood in the urine, or any discharge that was unnormal, and any swelling around the area, or if there was edema around the genitalia. So the next part we are going to do is I'm going to check your cap refills. Actually, before that, do you remember your last bowel movement?
No.
No. Do you know what a bowel movement is?
No.
When was the last time you went to the bathroom? Number 2.
Thought that might have been it. About 2 hours ago.
2 hours ago? Okay, and in a hospital setting, we would ask for their last bowel movement, or we would actually witness it, and in witnessing it, we would either be able to take samples from it if a lab was due for it, or we would actually be able to see if there was occult blood in the fecal matter. And also, as well as the pelvic exam, it also pertains to the anus and rectum exam. We would ask if the patient, have you ever had a hemorrhoid?
No.
Do you ever have trouble going to the bathroom?
No.
Are you ever constipated?
No.
Alright. So we'd ask questions like that, and then examining the anus, we would look for fissures, we would look for hemorrhoids, any issues like that. Again, masses, nodules, all that stuff. Alright, so the next part, we're going to actually check your cap refills, as we're just going to check the extremities, and we're going to check your grips, we're going to check your reflexes, and then we're going to be done. Alright? Alright, so I'm going to take this finger, I do the middle 3 fingers. Again, I'm just going to come down here. And also looking at the legs and feeling there is no edema in the legs or in the toes or in the feet. And also on the legs, the hair is evenly distributed. And for all cap refills of all 4 extremities, they were less than 3 seconds, which is a normal reading, which means that there is normal circulation occurring through the body, that the body is able to accommodate less than 3 seconds when oxygen is cut off from the fingers, and it's able to become from almost a whitish to a red in less than 3 seconds. So next I'm going to actually check your grip, so I'm going to sit down here. If I can have you sit up for me. Have you. Alright, so I'm going to pull. I want you to resist my pull. Alright? I want you to resist my push. Okay. I'm going to have you lay back for me. And bring your feet up. And put this down. Alright, and resist my push, like you're driving a car. And resist my pull. Alright, and I'm going to come up around here. And I'm going to have you push up against me with your shoulders. Try to get up. Alright. And resist me trying to pull you up. Alright. So, extremities with the grips, they are strong. He's able to resist back and is able to have full range of motion in doing that. Did they cause you any pain?
No.
They didn't cause the patient any pain. It was just a normal reaction to me pushing or pulling on the body. So lastly, we're going to check your reflexes. So I'm going to have you sit at the edge of the bed. So first we're going to do the patellar reflex. Okay. And now we're doing the Achilles reflex. Alright, and both reflexes were at a +2 grading, which is normal for reflexes, and they were accurate. There was no delay, which, from bringing back to the beginning of the video, that all of the cranial nerves are intact and that he's able to perform these tasks. I'm now going to have you lift this leg out, and I'm going to bring this other leg up, and I'm going to have you run your heel back across. Alright, you can put that down. And since he's able to do this, it shows us that that motor sensory part of his brain is intact and that he's able to perform tasks like that. If he was unable to perform that, we would then investigate further with some other range of motion tests that were more direct in dealing with the neurons themselves and the sensory of moving his feet and being able to do little mechanical movements of his body. All right. Do you need, how are you doing?
I'm pretty good.
Good? All right. Do you need anything else from me?
I think I'm good.
Do you need anything for me to bring back to the room, or?
No.
All right. Thank you.
Thank you.
All right. Thank you.